Welcome to the deep dive. You're here because you're curious, you want to get to grips with complex stuff, but without drowning in jargon.
And today, we are tackling something pretty specific. Atrioventricular valvular stenosis.
Right. Sounds complicated, but let's break it down.
Basically, it's a narrowing inside the heart. Affects the valves, the little doorways between the upper and lower chambers.
And our source for this pasted text, it defines it pretty clearly. We're talking about the mitral valve on the left.
Or the tricuspid on the right. And the narrowing is because the valve itself is malformed dysplasia, we call it. Or there's this obstructive tissue, kind of like a ring just above it.
Okay, so mitral, tricuspid. They're meant to ensure blood flows one way, right? From atria down to ventricles.
Exactly.
So if that pathway narrows, it's like a traffic jam trying to get through a single lane.
That's a perfect analogy. It creates this bottleneck. And the immediate consequence is increased resistance.
So the heart has to push harder.
It really does. To get the ventricles filled up properly, there has to be a higher pressure gradient, a bigger push from the atrium.
And the source mentioned these valves often leak too, regurgitation.
Yeah, that's a really key point. It's often not just stenosis, the narrowing, but also regurgitation, the leakiness. So the heart's struggling against the narrowing and dealing with blood flowing backward. Double trouble.
Wow. Okay, so it's inefficient, pushing hard, some leaks back. That sounds like it starts a chain reaction. That increased pressure, that's the first domino.
Precisely. That pressure builds up in the atrium, the chamber just before the narrowed valve. So what happens? It stretches, dilates.
It's bigger.
Right. And that back pressure doesn't stop there. It goes further upstream into the veins feeding that atrium, causes congestion.
And if that goes on long enough?
That's when you risk congestive heart failure. CHF. The heart just can't keep up with the body's demands anymore.
And where the fluid builds up depends on which valve is stenotic, right?
Yeah.
Mitral versus tricuspid.
Absolutely critical distinction. Mitral stenosis, left side, the backup, is into the pulmonary circuit. So you get fluid in the lungs. Pulmonary edema.
Directly impacting breathing. Very serious.
Very. Now, tricuspid stenosis, right side the backup, is into the body's general circulation.
So fluid where?
You tend to see it in the abdomen, that's ascites, sometimes in the chest cavity, around the lungs, pleural effusion, and occasionally you might even see this milky fluid called chylothorax.
Quite different outcomes depending on the side. Now, you mentioned something interesting earlier from the source about a PFO, persistent foramen ovale with tricuspid stenosis.
Yeah, that's fascinating. The foramen ovale is this little hole between the atria that's normal in a fetus but usually closes after birth.
Okay.
But if it stays open and you have high pressure on the right side because of tricuspid stenosis,
The blood takes a path of least resistance.
exactly. Poorly oxygenated blood gets shunted from the right atrium directly over to the left atrium, completely bypassing the lung.
And that leads to
Cyanosis, that bluish tinge you might see on the gums or skin because the blood circulating isn't carrying enough oxygen.
a worrying detour.
Uh-huh.
And cats, they have a slightly different thing sometimes. Supravalvular mitral stenosis.
Yes, in some cats, the issue isn't the valve leaflets themselves, but this ring of tissue above the mitral valve causing the obstruction.
Like an extra hurdle.
Pretty much. And the text notes this can sometimes go along with another defect, a partial atrioventricular septal defect, basically a hole in the wall separating the chambers.
Complex stuff. Now, one of the things owners might notice first is exercise intolerance. Why does that happen?
Well, think about it. If the ventricles can't fill properly because the doorway is too narrow,
They can't pump enough blood out.
especially when the body needs more, like during exercise, the muscles are demanding oxygen, but the heart just can't increase its output sufficiently, so the animal tires very quickly.
And faster heart rates.
Yeah.
The source said that's particularly dangerous with mitral stenosis, flash pulmonary edema.
That's a critical point. When the heart beats faster, there's even less time for diastolic filling, less time for blood to squeeze through that narrowed mitral valve.
So the pressure backs up even faster.
Dramatically faster. It can lead to a very rapid, severe buildup of pressure in the left atrium and pulmonary veins, causing that sudden fluid accumulation in the lungs, flash pulmonary edema. Life-threatening.
A really scary scenario.
Yeah.
And all this strain, it can mess with the heart's rhythm too.
Oh, absolutely. Irregular heartbeats are a big risk, especially atrial fibrillation or AFib.
What happens in AFib?
Instead of coordinated beats, the atria just quiver chaotically. This completely tanks the heart's pumping efficiency and actually makes the pressure gradient across that narrowed valve even worse.
And that can lead to high blood pressure in the lungs, pulmonary hypertension.
It can, yes. Especially with chronic mitral stenosis. The high pressure in the pulmonary vessels puts a huge strain back onto the right side of the heart.
Making it work harder, too.
Exactly. The right ventricle has to pump against this increased resistance in the lungs. This can cause the right side of the heart to enlarge and further worsen exercise intolerance. The source highlights this as particularly severe in cats with mitral stenosis.
Wow. It really is a domino effect, isn't it? One narrow valve triggers this whole cascade.
It truly is.
Let's talk about how this impacts other body systems. We mentioned the lungs with mitral stenosis.
Right. So besides the pulmonary edema, the fluid itself, that enlarged left atrium can actually physically squash the airways, the bronchi, makes breathing difficult.
Mechanically obstructing them.
Yes. And less commonly, you might even see coughing up blood hemoptysis. That can happen if tiny connections between lung veins and bronchial veins rupture under the pressure.
And fluid around the lungs, too. Pleural effusion.
That can happen, yes, particularly with tricuspid stenosis or sometimes in very long-standing complicated mitral stenosis. It can even cause parts of the lung to collapse atelectasis.
And with the tricuspid valves, the right side, we mentioned the liver.
Correct. The back pressure from tricuspid stenosis causes congestion in the liver and impairs blood flow through it. And that congestion is a major contributor to the fluid buildup in the abdomen, the ascites.
Okay, let's get to the why. Why does this happen? Is it genetic?
Well, in many cases, we actually don't know the specific genetic cause. It's often just considered congenital, present at birth.
But there are exceptions.
There are. The source specifically mentions Labrador retrievers with tricuspid valve dysplasia. Research found a link to a defect on chromosome 9.
Ah, so a known genetic factor there.
Yes, inherited in an autosomal dominant way, but with what they call reduced penetrance, meaning not every dog with the gene defect actually shows severe signs. Some might have it mildly or not at all.
Interesting. So genetics can play a role, but it's not the whole story for every case.
Precisely. But it tells us it's definitely a factor sometimes.
And overall, is this common?
No. The source says it's considered rare worldwide.
But more common in certain animals, dogs and cats.
Yes, primarily dogs and cats. And within those species, certain breeds pop up more frequently.
Which ones?
For mitral stenosis, we tend to see it more in bull terriers, Newfoundlands, and also Siamese cats.
Okay.
For tricuspid stenosis, think Old English sheepdogs and, as we just discussed, Labrador retrievers.
Makes sense with the genetic link. And usually diagnosed young.
Generally, yes. Most cases are picked up when the animal is young, though the source notes exceptions, especially in cats where it might be diagnosed later.
So if you're an owner, what might you notice at home? What are those first clues?
Probably the most common thing is reduced exercise ability. Your pet just can't run or play like they used to.
Gets tired easily.
Exactly. Fainting spells, syncope, that's another big warning sign. Difficulty breathing or breathing faster, especially with activity. A cough can be prominent, particularly with mitral stenosis. That bluish discoloration, cyanosis, we mentioned. A swollen belly, abdominal distension, especially with tricuspid issues. And in cats with mitral stenosis, watch out for sudden hind limb weakness or paralysis that can be due to blood clots.
That sounds terrifying.
It is. Other signs might be failure to grow properly, or even, though less common, coughing up blood.
Okay, so those are things owners might see. What about when the vet examines the animal? What might they find?
Well, a heart murmur is often the first thing detected. Classically, it's a soft diastolic murmur heard when the heart is relaxing and filling.
Diastolic, okay.
Yeah, listening over the left side suggests mitral, over the right suggests tricuspid. But interestingly, the source says a holosystolic murmur heard during pumping, indicating leakage is actually found more often.
So the leak might be easier to hear than the narrowing itself.
It seems that way sometimes. The vet will also check for fast or difficult breathing, listen for crackles in the lungs that suggest fluid.
What about signs related to the backup on the right side?
They'll look for swollen neck veins, maybe visible pulses in those veins, check for that abdominal fluid, ascites, and feel for an enlarged liver, hepatomegaly. And of course, checking mucous membrane color for cyanosis.
So putting the owner's observations and the vet's findings together starts to build a picture. Let's dig into the actual structural problems again. What's physically wrong with the valve?
The core issue is usually congenital malformation dysplasia. The valve leaflets themselves are often thickened, kind of stiff, and the edges, the commissures, might be fused together. That literally narrows the opening.
And the supravalvular ring in cats.
That's another primary congenital cause, yes. And it's not just the leaflets, the supporting structures, those little parachute strings called chordae tendineae, and the papillary muscles they attach to can also be abnormal.
And the atria get bigger.
Right, atrial enlargement is almost always there due to the pressure. And you might find those other associated defects like the PFO or the septal defect we talked about.
Are there causes that aren't congenital, things that happen later in life?
Yes, though they're much rarer. Things like infections settling on the heart valves, infective endocarditis, or heart tumors growing inside the chambers. Scarring from a specific heart muscle disease, hypertrophic cardiomyopathy, can also play a role.
Any other acquired causes?
The source specifically mentions acquired tricuspid stenosis in dogs due to scarring caused by pacemaker leads the wires placed through the veins into the heart.
Interesting. So mostly congenital, but sometimes acquired. We mentioned breeds as risk factors. Anything else?
Well, indirectly, anything that increases the risk of infective endocarditis would be a risk factor for that acquired form. And having those permanent pacing leads is a known risk for the acquired tricuspid stenosis.
Okay, so if a vet suspects this, based on the signs in exam, how do they confirm it? What's the diagnostic approach?
First step is often ruling out more common things that cause murmurs, like simple valve leakage without stenosis. The source also notes some other really rare heart conditions can mimic the signs.
Do basic blood tests help?
Routine blood work and urinalysis are usually done for general health assessment. They might show changes if there's heart failure affecting other organs or related to medications, but they don't diagnose the stenosis itself. Imaging is really key.
Starting with x-rays, thoracic radiographs.
Yes. Chest x-rays are very useful. That atrial enlargement we keep mentioning, that's usually pretty obvious. You might see generalized heart enlargement too, especially if there's leakage.
And specific signs for mitral versus tricuspid.
With mitral stenosis, you look for signs of lung congestion, pulmonary venous congestion, pulmonary edema. Sometimes bleeding in the lungs can even look like pneumonia on x-ray. With tricuspid stenosis, you'd look for that enlarged liver shadow, maybe a widened caudal vena cava.
But the definitive tool is echocardiography, ultrasound.
Absolutely. Echo is the gold standard. It lets you see the valve, see how it moves or doesn't move while.
What do you see specifically?
You'll see the enlarged atrium. You'll see the valve leaflets look thickened, irregular, maybe restricted in how they open during diastole. They might have that characteristic doming appearance. If there's a supravalvular ring, you can often visualize that directly.
And you mentioned different echo modes, M mode and Doppler.
Right. M mode gives you that sort of ice pick view over time. It can show abnormal leaflet motion and a decreased E to F slope, which is a specific measurement related to mitral valve opening speed.
And Doppler, that's about blood flow.
Exactly. Color Doppler shows you the direction and turbulence. With stenosis, you'll see this turbulent jet of blood shooting through the narrow valve during diastole. It also clearly shows any valve leakage going the wrong way.
What about spectral Doppler?
Spectral Doppler lets you measure the speed of that jet. Higher speed means a tighter stenosis. From that speed, you can estimate the pressure difference and calculate things like the pressure half-time, a key measure of severity. A longer half-time means more severe stenosis. It can also pick up subtle changes in flow patterns early on.
So echo gives a really detailed functional picture. What about older techniques like angiography or cardiac catheterization? Still used.
Angiography injecting dye can sometimes help visualize the anatomy, like a really big atrium in TS, or show shunting through a PFO if dye crosses over. It might show the thickened valve or leakage.
And catheterization, putting tubes in the heart.
That's the most direct way to measure pressures. It will clearly show that pressure difference between the atrium and ventricle during diastole, which is stenosis. You can measure the high pressures in the atria and associated vessels. It's invasive, though, so echo is usually preferred for diagnosis now.
Makes sense? Lastly, the ECG. What does that tell us?
The ECG looks at electrical activity. It can show patterns suggesting atrial enlargement, those tall or wide P waves. Sometimes specific QRS changes, like splintered R waves in dogs with tricuspid dysplasia. It can show if the heart's electrical axis has shifted due to chamber enlargement.
But mainly for rhythms.
Critically important for detecting arrhythmias, especially atrial fibrillation. AFib is so common and has such a big impact, the ECG is essential for identifying and monitoring it.
Okay, that covers diagnosis pretty thoroughly. We talked about the valve pathology, thickened, fused leaflets, maybe a ring, abnormal supports, atrial enlargement.
And potentially those associated defects like PFO or AV septal defects.
Right, so let's turn to treatment. An animal is diagnosed, maybe even in heart failure. What's the first step?
If they're in overt congestive heart failure, it's an emergency. They need hospitalization, oxygen, medications to get the fluid off immediate stabilization.
Then think about longer term.
Exactly. Once stable, you can consider next steps. Controlling any arrhythmias, especially AFib, is crucial right from the start. And these are complex cases, so consulting with a veterinary cardiologist is really recommended.
What about things like electrical cardioversion for AFib?
It can be attempted, trying to shock the heart back into normal rhythm. But the source points out, if the atrium is really diseased and stretched, the AFib often comes back pretty quickly, so it's not always a lasting fix.
What about supportive care in the hospital?
Sedation, like with butorphanol, can help ease breathing distress. Oxygen therapy is vital if they're hypoxic. Careful with IV fluids, though usually avoided in severe heart failure unless there's another reason like kidney issues or dehydration.
And draining fluid.
Yes, if there's significant pleural effusion or ascites causing breathing problems or discomfort, therapeutic paracentesis draining the fluid with a needle might be necessary.
And lifestyle changes are key, you mentioned.
Absolutely critical. Strict exercise restriction. Any increase in heart rate worsens that pressure gradient across the stenosis, increasing the risk of fluid buildup. Cage arrest if they're in heart failure.
Diet.
A low-sodium diet is generally recommended to help manage fluid retention in heart failure patients.
And owner education sounds vital.
Hugely important. Owners need to recognize the signs of returning heart failure, difficulty breathing, cough, lethargy, swollen belly, and know it needs urgent attention, especially the potential for flash pulmonary edema with mitral stenosis. They need to understand it can be a recurring issue and how serious AFib is if it develops.
Are there surgical fixes? You mentioned valve replacement earlier.
Open heart surgery for valve repair or replacement exists, but it's very specialized, expensive, high risk, and not widely available.
What about the balloon procedure? Valvuloplasty.
Balloon valvuloplasty is a less invasive option, done via catheterization by specialists. They thread a balloon across the narrowed valve and inflate it to stretch it open. The source says it has been successful in some cases, so it's a potential referral treatment.
Okay, let's talk medications. This seems like the main approach for many. Managing heart failure.
Yes. Diuretics are key drugs like furosemide to get rid of excess fluid. The source gives typical dose ranges for dogs and cats.
What else for heart failure?
ACE inhibitors, like enalapril. They help relax blood vessels, reduce the heart's workload. Again, doses are provided, and monitoring kidney function and blood pressure is important.
Any others?
Nitroglycerin paste is sometimes used topically to help reduce pulmonary venous pressure, but its effectiveness isn't super well established.
What about controlling those fast heart rates, the arrhythmias?
If AFib or other atrial tachyarrhythmias are present, you need rate control. Digoxin can help slow the rate. Monitoring blood levels is important.
Beta blockers.
Huh?
Calcium channel blockers.
Yes, drugs like atenolol, a beta blocker, or diltiazem, a calcium channel blocker, are often used to slow the heart rate and reduce extra beats. Need to be cautious starting them if heart failure isn't fully controlled. Start low, go slow with dosing. Sotalol is another option for tricky arrhythmias.
And the pulmonary hypertension. High pressure in the lungs.
Sildenafil, yes. The drug also used for erectile dysfunction can help relax the blood vessels in the lungs. The source gives dosages for dogs.
Are there any meds to be particularly careful with?
Pimobendan. It's a great drug for many types of heart failure, but for pure stenosis without much leakage, it's generally not recommended because increasing contractility might worsen the pressure gradient. If there's significant leakage in heart failure, it might be used cautiously.
Anything else?
Just reinforcing the need for caution with ACE inhibitors and other vasodilators that can drop blood pressure too much, so monitoring is key.
Any important drug interactions to know about?
Furosemide and ACE inhibitors together can impact kidneys, electrolytes, and blood pressure, so monitoring is needed. Sildenafil shouldn't be used with nitrates because both lower blood pressure significantly.
Are there alternative meds?
Spironolactone is sometimes added as a second diuretic. It has weaker diuretic effects, but might also help reduce fibrosis or scarring in the heart muscle over time.
So managing these patients requires ongoing monitoring. What does that involve?
Regular checkups are essential, often involves repeat chest x-rays to check for fluid. If they're on sildenafil, repeat echocardiograms to monitor pulmonary pressures and right heart function.
Lab work. ECGs.
Monitoring kidney values and electrolytes, especially with diuretics and ACE inhibitors, checking digoxin levels if used, monitoring blood pressure, and regular ECGs or Holter monitoring, a 24-hour ECG, if arrhythmias are a concern.
What are the main complications we worry about long term?
Worsening heart failure is the big one, developing atrial fibrillation, fainting spells, blood clots, particularly arterial thromboembolism in cats with mitral stenosis, and that potential for bleeding in the lungs with mitral stenosis.
Given all that, what's the outlook, the prognosis?
Well, the source is quite guarded. Morbidity, meaning the impact on quality of life, is high. Once symptoms develop, the prognosis is generally considered poor unless it's a very mild case.
But not always hopeless.
No, definitely not. Some animals, especially with diligent management, can live for many years even with significant stenosis. And those interventions, like balloon valvuloplasty or surgery, while carrying risks, might improve the outcome in selected patients, though we need more long-term data.
This has been incredibly detailed. Thank you. It really paints a picture of atrioventricular valvular stenosis as a really serious bottleneck in the heart.
It is a narrowing that sets off this whole chain reaction affecting the heart, lungs, liver, the whole system.
And it underscores how crucial early detection and really careful tailored management are, even if the overall prognosis can be tough.
Absolutely. We've covered a lot, drawing from the source text, the mechanics, the effects, how it's diagnosed, the different treatment strategies. Hopefully it provides a solid foundation.
And for you listening, maybe parts of this sparked more questions, or perhaps it relates to a situation you know. We hope this deep dive helps you understand it better and encourages you to explore further or talk to veterinary experts if needed.
And maybe a final thought to leave you with. Just consider how incredibly intricate the heart's design is, and how a seemingly small structural change like this valve narrowing can have such profound system-wide consequences. It really speaks to the complexity and maybe the fragility of biological systems.